So this is my work area. There's no papers or anything, just my tools are right there. All right. Hi, my name is Priya Alexander. I'm a PA student, and today I'm going to be performing a head, eyes, ears, nose, and throat exam. I'm going to go wash my hands with soap and water, and I'll be right back. Okay, so my patient seems healthy and no apparent signs of distress. First, I'm going to be inspecting the head for symmetry, shape, contours, and deformities. So the head is normocephalic. Next, I'm going to be inspecting the face for symmetry, skin lesions, discolorations, and edema. The face is symmetrical and there's no apparent lesions. Next, I'm going to be inspecting the hair for hair distribution. So looking around, the hair is symmetrical in distribution. And I'm also going to be inspecting and palpating for the quality and texture of the hair and any lesions, scaling, or lice, and none of that's present, and the hair quality is good. Now I'm going to be palpating the cranium and the temporal artery. So I'm just going to palpate the entire head and then palpate the temporal artery. So there's no masses or tenderness elicited, and the temporal artery is not tender. Now I'm going to be palpating the paranasal sinuses. So I'm going to be palpating the frontal sinuses, maxillary sinuses, and there's no masses or tenderness elicited. Now I'm going to be palpating the parotid glands bilaterally. So when I palpate them, there's no tenderness, and they're free from any irregularities or nodules. Now I'm going to be placing my hands on the TMJ joint, having the patient open and close his jaw, move it from side to side, and just protrude it outwards. Okay, so the TMJ is free from any crepitus or grinding. Now I'm going to have the patient clench his jaw, and I'm going to be palpating the temporal and masseter muscles for any tenderness. There's none present, so cranial nerve 5 is intact. Now I'm going to be examining facial expressions. I'm going to have the patient raise his eyebrows up and down, close his eyes, and I'm going to gently tug, frown, smile, and puff out the cheeks. So cranial nerve 7 is intact. Now I'm going to be examining the eyebrows, eyelashes, and eyelids for symmetry, for any skin lesions, periorbital discolorations, exophthalmos, or edema. So everything seems symmetrical and none of those features are present. Next, I'm going to be palpating the nasolacrimal duct and the lacrimal gland. So I'm going to start around the bony orbit and then go upwards on the nasolacrimal duct, and there's no regurgitation present. Next, I'm going to be examining the palpebral and bulbar conjunctiva and sclera. So I'm going to have the patient look directly at me. I'm going to lift up the eyes a little bit, down. So the sclera is white, the conjunctiva is pink, and there's no evidence of foreign bodies, any lesions, any icterus, or any injection. So now I'm going to be starting the visual acuity portion of the exam. I'm going to hold this 14 inches for my patient's face, and I'm going to have him read the smallest line while covering his left eye first.
428739.
And now with the other eye.
428739.
And now with both eyes.
428739.
So OD is 20/20, OS is 20/20, OU is 20/20, cranial nerve 2 is intact. Now I'm going to be examining visual fields by confrontation. Whenever you see my hands, I just want you to point at them when I come around your periphery. Okay, so all visual fields are intact. Next, I'm going to be examining the 6 extraocular eye movements. I'm going to have the patient follow my finger without moving his head. Okay, so all 6 EOMs are intact with good range of motion, with no presence of nystagmus or lid lag. Cranial nerves 3, 4, and 6 are intact. Now I'm going to be examining for convergence. I'm going to have the patient follow my finger to the bridge of his nose and then look at something far behind me when I get close to your nose, okay? And then look at something far behind, okay? So the eyes are able to converge and the pupils accommodate to near vision. Next, I'm going to be examining the anterior chamber and cornea depth. I'm going to be shining my light laterally on both of the eyes, and there's no crescent shadow noted. Next, I'm going to be evaluating the alignment and position of the eyes. So I'm going to be shining my light down the bridge of the nose and looking at the eyes, and the light reflection is present on both of the eyes. Now I'm going to be doing the cover and cover test. So I'm just going to have the patient look directly at me. Okay, so there's no strabismus noted on either of the eyes. Now I'm going to be examining the pupil's direct and consensual response to light. I'm going to be shining my light in both of the eyes and then looking at the opposite eye when I shine the light in one eye to test the consensual response. So the pupils are equal, round, reactive to light and accommodation. And on inspection, the pupils are about 3 millimeters in size. Now I'm going to be performing the ophthalmologic portion of the exam. I'm going to dim the light. Making sure my diopter is at 0. I have good light on the scope. And I'm going to go in at a 45-degree angle, examining the patient's right eye first with my right hand, and then lift up. And you can go ahead and focus on something over there, and you can blink as much as you want, okay?
Okay.
So I'm going to go in at a 45-degree angle. The red reflex is present. The cornea, anterior chamber, lens, and vitreous are clear. The disc is yellow-orange, the margins are sharp, and the cut-to-disc ratio is 0.5. The AV ratio is 2 to 3. There's no evidence of nicking or spasms, no hemorrhages or exudates. Go ahead, look directly in the light. The macula is undistorted without lesions. Now I'm going to be using my left hand to examine the patient's left eye, and also using my left eye. So again, I'm just going to pull up behind the eye, go at a 45-degree angle. So the red reflex is present, the anterior chamber, cornea, lens, and vitreous are clear, the disc is yellow-orange, the margins are sharp, and the cut-to-disc ratio is 0.5. The AV ratio is 2 to 3. There's no evidence of nicking or spasms, and there's no hemorrhages or exudates. And now just go ahead and look directly at the light. The macula is undistorted without lesions. You can change it. So I'm going to make sure the lights are turned back on. Now I'm going to be moving on to the ears. I'm going to be palpating the auricles bilaterally and looking for any lesions or discharge on both of the ears. I'm going to be palpating the tragus, making sure it's non-tender. I'm going to be looking at the mastoid color and making sure that there's no discoloration. And I'm also going to be palpating the mastoids bilaterally just to make sure there's no tenderness or masses elicited. Now I'm going to be using my otoscope to look inside of the ears, making sure my light is on the brightest setting, making sure to pull back and out on the auricle, bracing my patient's face with my hand, and then making sure to place my scope before I look. Okay, so going back and out, placing and looking. The canals are unobstructed. The tympanic membrane is pearly gray and translucent with the light reflecting the anterior inferior quadrant. The malleus umbo, pars tensa, and pars flaccida are undistorted. There's no evidence of fluid in the middle ear. Go ahead and Valsalva. Okay, so the tympanic membrane is mobile. Now I'm going to be doing it on the other side. Again, pulling on the ear, back and out, placing my scope before I look, and bracing my patient's face with my pinky. So the canals are unobstructed. The tympanic membrane is pearly gray and translucent with the light reflex in the anterior inferior quadrant. The malleus, umbo, pars tensa, and pars flaccida are undistorted. There's no evidence of fluid in the middle ear. Go ahead and Valsalva. Okay, the tympanic membrane is mobile. Now I'm going to be testing for auditory acuity. I'm going to have the patient close his eyes and just tell me where you hear the sound. Okay, so cranial nerve 8 is intact. Now I'm going to be performing the Weber and Rin tests. I'm going to be striking the tuning fork, placing it on your head, and just tell me where you hear the sound.
In the middle, both ears.
Okay? Now I'm going to be striking the tuning fork, placing it behind your ear, and when you can't hear it anymore, tell me.
Can't hear it anymore.
Can you still hear it?
Yep.
Okay? And we're just going to do it on the other ear.
Can't hear it anymore.
Can you still hear it?
Yes.
Okay? So the Weber is midline, and air conduction is greater than bone conduction bilaterally. Now we're going to be moving on to the nose. The nose is midline without any apparent deviations. I'm going to have the patient occlude one nostril and breathe in. Occlude the other nostril and breathe in. And then I'm going to be grabbing 2 cents. I'm going to have the patient close his eyes, occlude one nostril, and then tell me what you smell.
Cinnamon.
Okay, occlude the other nostril. What do you smell?
Chili peppers.
Okay, so cranial nerve 1 is intact. Now I'm going to be examining the nose. I'm going to be making sure to brace my hand against the patient's face, having his head tilted back posteriorly. Going to place my scope before I look. And then slightly move the head downwards. Keep moving. So the mucosa is pink without any apparent lesions, and there's scant rhinorrhea present. I'm going to be doing it on the opposite nostril. I'm going to be placing my scope, tilting the head back. Okay, and then move your head down. The mucosa is pink without any apparent lesions. There's scant rhinorrhea present, and I can visualize the septum and the turbinates. Okay. So now I'm going to be moving on to the oral portion. I'm going to be putting my gloves on. So on inspection, the lips are pink and moist without any ulcers or cracking. I'm going to be first inspecting the oropharyngeal mucosa. So I'm going to have the patient open his mouth, place my tongue depressor, and I'm looking for any white patches, nodules, or any color deviations, and none is present. I'm going to be inspecting the breath odor, which is non-offensive. Now I'm going to be inspecting the gingiva to make sure it's free from any lesions or inflammation. You can go ahead and open your mouth, under your tongue, and just the side, put your tongue down. So it's free from any lesions or inflammation. Now I'm going to be inspecting the teeth. So I'm going to have you open up your mouth. I'm just going to rake the back teeth. And then bite down. And I'm just going to tap. So the teeth are in good condition with good oral repair and good hygiene, and they're also non-tender. Now I'm going to be inspecting the uvula. So I'm going to have the patient open his mouth and say ah.
Ah.
So the uvula is midline, rises with phonation, cranial nerve 10 is intact. I'm also going to be inspecting the back of the mouth to see the tonsils. Go ahead and stick your tongue out. The tonsils are absent in the back of the mouth. At this point, I would be inspecting for a gag reflex, and if it was present, cranial nerves 9 and 10 would be intact. Now I'm going to have the patient stick out his tongue, move it from side to side. So the tongue is without lesions, able to move from side to side, so cranial nerve 12 is intact. Now, I'm going to be examining the surfaces of the tongue. Go ahead and stick your tongue out. I'm just going to grab the tongue with the gauze and just inspecting for any color, any lesions, and none is present. Now I'm going to be inspecting the Whartons and Stenson's ducts. So I'm going to have you open your mouth, and I actually have to put my hands in your mouth. I'm going to be palpating on this side, the Stenson's and Wharton's ducts, on the opposite side, and then I'm just going to go around the gum line as well. So there's no masses or stones present, no tenderness, and no areas of induration. Now I'm going to be examining the trachea on inspection. It's midline and mobile without any deviations. I'm also going to be inspecting the skin for any color deviations, scarring, lesions, or moles. There's none present. Now I'm going to be palpating the lymph nodes. So I'm going to be starting with the occipital lymph nodes in the head, in the back of the head, and then postauricular lymph nodes, preauricular lymph nodes, tonsillar, submandibular, submental, and then the deep cervical chain, posterior cervical chain, anterior cervical chain, and supraclavicular. And I'm also going to be checking for the epitrochlear lymph node. So I'm just going to be palpating right here, and on the other side, be palpating as well. So there's no lymphadenopathy noted and no tenderness. Now I'm going to be inspecting the thyroid gland. So I'm just going to be palpating downwards to make sure there's no tenderness. I'm going to be locating the cricoid cartilage, which is right here. I'm going to be locating the cricoid cartilage and the thyroid lobules, and then I'm going to come around the patient, have him swallow, and then make sure to feel all the way down. Make sure everything is symmetrical. Now I'm going to have you put your head down and move to one side, a little bit more. Yep. No. Yep, that's fine. I'm going to be displacing the trachea and palpating with my other hand. And then move your head to the other side. I'm going to be moving the trachea again, and then palpating all the way down. Okay? So the thyroid is normal in size, shape, and consistency without any nodules or irregularities. Now I'm going to be testing the 6 ranges of motion. So I'm going to have you put your chin to your chest. I'm going to have you look up at the sky. Put your left ear to your left shoulder. Put your right ear to your right shoulder. And then go ahead and rotate your face like this and rotate your face like this. Okay? And now I'm just going to be testing the SEM and shoulder shrug against resistance. I'm going to have you shrug your shoulders up, and I'm just going to put pressure on them. Okay? That's fine. So cranial nerve 11 is intact.